Hello, my name is Dr. Yuri Quintana. I'm the Chief of the Division of Clinical Informatics at Beth Israel Deaconess Medical Center and Assistant Professor of Medicine at Harvard Medical School. And I'm delighted today to be joined by Dr. David Einstein to share with you work we're doing to develop a network across our healthcare network. David?
Hi, and thanks, Yuri, for the invitation. I'm David Einstein. I am a genitourinary medical oncologist, specializing in prostate, bladder, testicular, and kidney cancers. I am an assistant professor of medicine at Harvard Medical School, and I also direct genitourinary oncology research for the Beth Israel Lahey Cancer Network.
Great. So Dr. Einstein and I have been working together with colleagues at the Beth Israel Deaconess Medical Center Cancer Center and across our BILH Beth Israel Lahey Health Network to develop tools to be able to allow us to collaborate across the network and improve healthcare delivery. Today we're going to be talking to you about Alicanto, a platform that's been developed here at Beth Israel in the Division of Clinical Informatics and is being used for both online learning and collaboration across the healthcare system. And it was deployed right before COVID hit, and so we'll be able to explain to you what this platform is, how it was scaled, some of the challenges that we've had, and some lessons learned that we hope will be useful as you plan your future directions in your collaborative platforms. So I'd like to begin sort of with some of the learning objectives. We're going to be talking about this platform in terms of understanding what a learning health network is. It's a formal concept that has specific goals, and we're going to describe some of those goals. And then we're going to review some other implementations that there have been in the past for learning healthcare networks, and what are some of the barriers in terms of creating these networks. We're then going to tell you about the platform that we've built here at Beth Israel Lahey and discuss what strategies we used, and then talk about what are some future directions and suggestions that we have in the post-COVID world. So as disclosure, as I've mentioned, Alicanto, it's a learning platform. It's owned by Beth Israel Deaconess Medical Center. It was developed by myself and staff here at Beth Israel Deaconess Medical Center. What is the learning health system? And this concept has been around for a long time, but in the last decade, it's sort of gotten more focus in terms of what it is and how to develop it and how to evaluate it. And lots of different groups have looked at this. So there was something called the Institute of Medicine, which is now called the National Academies of Medicine, that developed a series of publications over the last 15 years describing what are the objectives of trying to develop scalable healthcare solutions that take the best evidence, implement them in terms of healthcare delivery strategies, and puts them into operation. And at the same time as you're scaling this, be able to collect information for what is working, what isn't, and then be able to integrate that back in terms of quality improvement processes. As you know, there is an enormous amount of evidence being published in science and medicine, and so it takes a lot of effort to distill that and translate that into healthcare pathways, evidence-based guidelines, and then turning those guidelines into operational methodologies. All of that requires education, training, and planning. And so this shows you from Academy Health report some of the different strategies and how you might be able to do this across the continuum of a healthcare system. And it's particularly relevant for us because Beth Israel Lahey Health is a collection of 13 hospitals and 17 affiliate hospitals. So it's a very large network, and we have everything from large academic medical centers to community-based hospitals. And so sharing the knowledge, standardizing care, and coordinating care across a large network is a challenge not only for us, but many other healthcare systems which are also growing both in terms of size and collaborations with other hospitals. And so the learning healthcare system produced a bunch of reports. One of them is the one you see here. And in 2007, they had the goal that by 2020, 90% of clinical decisions would be supported by accurate, timely, up-to-date clinical information that reflects the best available evidence. And while this was a worthwhile goal, we're actually not achieving that at this point. And part of the reason is that it takes a lot of effort to take that evidence, that knowledge, and scale it across a network. And so there's a lot of work going on right now to sort of figure out what's the best, most efficient way of taking that knowledge and disseminating it. As you know, there are professional societies and medical societies that meet usually once a year, some more often regionally, and those are good places to sort of learn about the latest evidence. But it takes a lot more effort then to take that knowledge and then implement it within your local organization. That requires peers to sort of get together to review the evidence, figure out how to apply that in their local context, implement that, and as they implement it, they learn what is working, what isn't working. And so one of the ideas of the system is to develop communities of practice where healthcare professionals start sharing implementation knowledge within one hospital with another hospital so they can learn from each other and understand operational improvements and also how to update their practices to the current evidence. There's been many different reports trying to see how to take evidence-based medicine and bring it into operational use with high quality. The first papers on this appeared in the late 1980s and early 1992. There was a seminal paper on evidence-based medicine by David Sackett and many others from McMaster in Canada and other organizations, which resulted in some formal books that sort of describe how to distill that information and take it into operational implementation science. And there's been several reports subsequently looking at what are the problems in terms of bringing that knowledge into practice. And despite all our best efforts, by 2016, for example, medical errors were the third leading cause of death in the United States. And today it remains one of the major problems. So taking knowledge and implementing it in high quality at scale is a huge challenge. So how do we build platforms and technologies that allow us to collaborate? And so the idea of this really comes from many decades of systems engineering and quality improvement methodologies, where a community will get together to agree on some targets that they want to achieve in terms of their healthcare delivery, looking at what the best evidence is, deciding on what clinical practice they want to, clinical guidelines and operational methods they want to implement, training their staff on how to implement those care guidelines, and then doing data collection for quality improvement, which then can hopefully feed back to the people who are reviewing the evidence to be able to do new targets and new improvements. This is nothing new. It's been happening for decades. And what is new is how to take all of these components and systematically connect the dots and create collaborations across large hospitals and between hospital networks. And so to do this requires a very detailed analysis of what types of care delivery you want to deliver, what kind of training people need, who needs that training, and to be able to make sure that people have the right knowledge, the right training, and right competencies. And so there have been efforts, for example, from the education community to do detailed analysis of competencies and trying to deliver training. That needs to align with whatever care guidelines are being developed, and it also must align within the technologies that you're using to both keep track of the delivery of that and track outcomes. All of these things in the past have done and been done somewhat in silos. So there's an education group, a quality improvement group, a systems technology group. And the idea now is how do we get more coordination across these different groups and different communities and systems. And so what are some examples of groups that have done this successfully? So I was involved in a community of practice of pediatric oncologists for about 12 years. And this group was based out of St. Jude Children's Research Hospital in Memphis, Tennessee, and that hospital was working with different hospitals around the world to disseminate best practices and knowledge to improve pediatric oncology care. And in Central America, for example, several hospitals were trying to collaborate in the 1990s to improve how they delivered care. And one of the things that they were doing is meeting once a year to review the evidence and develop practice guidelines. Um, and in 2002, I joined that organization to help develop an online platform to allow doctors to be able to meet online, to help accelerate the development of evidence-based guidelines and how to translate them to operational strategies that they could implement in their local hospitals with the resources that they needed. And so at the time, survival rates were quite low in those countries, but they realized that not only they needed to have the best evidence, but they needed to be able to meet to develop those adapted guidelines and strategies for implementation based on their resources. And so they needed a place to not only learn, but also meet and be able to collaborate. And so a platform was developed called Cure for Kids, which had the latest evidence, but also gave them access to collaborative spaces for them to be able to meet online, develop those care practice guidelines, and as well be able to have virtual tumor boards where they could meet and discuss difficult cases that didn't actually match some of the guidelines and needed special discussion for how to treat. This network grew from Central America, and over a 12-year period, 400 communities of practice were formed on the Cure for Kids platform, sharing best practices regionally organized by different cancer topics in pediatric oncology. And many of these groups were very successful at developing guidelines, implementing them locally, collecting quality improvement metrics, and then meeting online to share some of those implementation and outcome strategies so that they can learn from each other. And many hospital networks across different parts of the world were able to substantially increase their survival rates of their children by not only improving locally, but collaborating globally. And so here you see an example of doctors both in Rabat and Casablanca who were meeting online and discussing virtual tumor boards, and there are some publications that discuss some of these web conferences for virtual tumor boards. And so this extended not only to virtual tumor boards, but then in terms of collecting outcomes, and groups were then implementing common protocols for care guidelines and collecting data in standardized forms, which they had agreed on the data formats. And then they were able to compare outcomes and be able to analyze why there were differences in outcomes. And so groups were able to help each other, for example, identify problems with infection control or problems with abandonment or other issues, and were able to sort of band together around those common problems to work together to come up with solutions that they could implement simultaneously across multiple centers. So a data platform called Pawn for Kids was created to be able to share outcomes data in anonymized formats that allowed centers to be able to compare how their center was doing on common types of patients and common types of protocols. And over a 12-year period, some of the cancer centers were able to raise their survival rates from 20% to over 50% for some types of common cancers in pediatric oncology. And this was replicated not only in Central America, but across other parts of the world. And beyond just having an impact in pediatric oncology, this had an impact on other groups, other disease groups, who then started copying the similar methodology of communities of practice to be able to collaborate on both training, but also implementation and outcomes analysis. So what are the challenges that there are in creating these communities? Part of it is sometimes initially trying to collect too much data, and you need to focus on certain diseases and certain types of key priority data outcomes that you want to collect. But it also requires groups to agree on what are those metrics that they want to be able to compare, how do they want to collect that, the common types of medical vocabularies and taxonomies, and then have some common tools for them to be able to analyze those outcomes and be able to learn from each other. And so we produced several publications talking about some of these types of collaborations and developing a strategy to enable these communities to be able to move forward faster. So fast forward then to 2014 when I joined Harvard Medical School and the Division of Clinical Informatics at Beth Israel Deaconess Medical Center. And I decided to sort of continue this sort of line of work of communities of practice and think about more advanced platforms that would allow further collaboration, both in education, but also in terms of virtual tumor boards. And so we deployed a version of a new platform called Alicanto. And Alicanto is a platform where both doctors, nurses, and other healthcare professionals can meet online, have collaborative spaces to share educational material through their library, and this could be the latest evidence based knowledge, but also have collaborative spaces for groups to meet online and then create new practice guidelines or create virtual tumor boards to be able to meet and discuss difficult cases. And we deployed this in 2019. Versions of Alicanto had existed for a few years before that we had piloted at other hospitals, but at BI it went live in 2019. And in January 2020, we started having our first virtual tumor boards across the cancer network. And as you recall, in January 2020 is when COVID sort of started appearing within the United States. And so it was a very timely opportunity to be able to use this platform to provide a way for our doctors and nurses and other staff to be able to collaborate online. So the reason it's called Alicanto is because as I view healthcare, we live in a lot of silos. We have different systems that are sort of islands unto themselves sometimes. We have different groups who sometimes don't communicate enough. And Alicanto is trying to integrate communication and access to information and collaborative tools. It's based on a mythical bird from southern Chile, where my ancestry comes from, and it's a country of mines. And this mythical bird glows in the darks and helps miners come out of mines. And so Alicanto is sort of like that. It's a platform that allows people to sort of be able to communicate no matter where they are in a large hospital network and to be able to work together. Over the last year, the platform has grown in use. We have over 1,000 users, and about 800 of those are part of the cancer community, not only at Beth Israel, but on community hospitals, and we have a growing number of users using this. And this gives you just a very high-level overview of this system that allows information for different groups and to be able to both provide online education, virtual tumor boards, and more recently, we're using it for patient referrals. And so I'd like to pass it over to Dr. David Einstein, who will be talking about the implementation, and he has been one of the key leaders who has had tremendous success in using this within the platform. And I will ask David to talk about his experience in leading the growth of this platform. David?
Sure. So thanks again for having me, and big thanks to Yuri for working with us through the trials and tribulations of COVID and all the clinical challenges that we encountered. So before COVID, we in GU Oncology had a very good collaborative group composed of medical oncologists, radiation oncologists, urologists, and then we would meet weekly with our diagnostic radiologists and pathologists to go over cases and talk about challenging case management. In the old world, when we were meeting in person, we would send out a weekly spreadsheet full of individual cases that had been emailed to one central receiving person, and then that list would go out, but inevitably there would be a lot of last-minute add-ons and multiple versions of Excel spreadsheets created. A very inefficient system. And so those were some of the challenges that we were facing, especially as we started migrating towards virtual tumor boards. And so we'll talk a little bit about how we've tried to address that within GU. But we're composed of the group at the IDMC with these different subspecialists, and then increasingly we're practicing as part of our network with outside medical oncologists and urologists wanting to meet with us and review cases or ask us for second opinions. So that sort of highlights the group collaboration efforts that have gone on, as well as these virtual tumor boards that we're using for case discussions. One thing that we had never done before that we're now potentially able to do with the new system is to actually review all the cases that we have been discussing and mine those data for quality improvement purposes. And then finally, for an education perspective, this is very useful since a lot of the questions that we wrestle with in tumor board are the key controversies in the field, and so we can then use that to develop training for fellows and have an educational component as an academic institution. So you'll see over on the right side here that we have a variety of different groups with different memberships. And we've been using the PIDMC GU Oncology for our virtual tumor boards. And then I belong to several of these other groups as well that have different reach. So we can go to the next slide. So here is a view of the homepage when you come in to Alicanto and then click to one of these groups. And you'll see that there are a number of options across the bar with the option for scheduling video conferences that are hosted by external services. We can post resources and have collaborative tools, things that we're commonly referencing, things like practice guidelines or state-by-state telemedicine requirements. These are things that we're frequently trying to go through buried emails to find, but now we can post them in a central location. We can manage our membership, and then we'll get to the consult system as well, which is how we organize our tumor boards and have started to organize our network referrals. Next slide. So here is an example of a video conference. This is our virtual tumor board that has been happening weekly. And we can meet online for these case discussions that we used to do in person. Notably, even as we have all gotten vaccinated and can now spend time with each other in the same place, many of us feel that probably we will never go back to in-person meetings because it's so much more efficient to do it this way and because it works out so well with the network-based practice. So if we wanted to submit a case for discussion at Tumor Board, we could use this consult system either via this browser-based entry or via an app. So we can go to the next slide. So if I were to enter the consult system, I would have the option for creating a case. And this case form has a lot of different data fields that we can customize depending on the needs of each group. And moreover, when we use this as a case submission system for referrals, there's going to be a different set of questions versus the questions that we're going to ask of a patient being presented at Tumor Board. So we indicate our group where the patient is being cared for. We have a subset of diseases that's specific to GU. So a breast cancer case should not be discussed at GU Tumor Board, so there's only GU cancers to choose from. We indicate some basic demographics. We can indicate a date to be scheduled. And if an admin or a nurse is putting in a case for an attending physician, they can indicate who that attending physician is. Otherwise, if I'm doing it myself, I don't need to indicate that. So I would add a brief case description and some questions for discussion. And then I think a real highlight of this system is the ability to tag key specialties. So a lot of times we're reviewing diagnostic images and or pathology results, biopsies and specimens. And it's very helpful for the people who are presenting these at our tumor board to know in advance which cases to pull and review. So we can indicate whether or not we have a pathology question or a radiology question. and the receivers on the other end can actually set their notifications to be notified specifically when there is a pathology request and or a radiology request. Next slide. This is the case dashboard. So once I submit that case, it would appear on this case dashboard. And I can customize my view to see multiple groups or just one group. You can also sort things. You can archive old cases and view them or not as you wish. You can organize them by you can sort the list by each of these variables across the top row. You can also filter, for example, by I only want to see prostate cancer cases that have been submitted within the last year or so. That might help me with QI or research projects. And then finally, you can export this dashboard again for QI and research efforts. Next slide. So this is the mobile app that's been developed as well. So frequently we're working off of our iPhones or our iPads in clinic. Frequently we're not sitting by one desktop throughout a whole clinic session. And so this app is really invaluable for being able to enter data and review on the go. So you can set up notifications and get notified that way of meetings and content. You can join meetings through the app. We can access our groups. Importantly, we can access the consult system. So if I'm sitting in the clinic room with a patient and I have a question that I want to make sure is addressed at tumor board, I can right then and there click the consult button and enter all those case details so that I won't forget to do it after a busy clinic session. There's a library where we're beginning to develop practice guidelines and online learning videos, including even videos for how to go through this system and set up your own tumor boards. Next slide. So this consult system is really a system within a system, and we've been using it for anything that requires patient protected health information, and it is stored in a secure server behind a firewall. Requires two-factor authentication on the initial login, and then if you have your cookies set, subsequent logins don't require an additional two-factor authentication. So within that consult system, we've built a variety of tumor boards, and then increasingly we're trying to use the same system to manage the many patient referrals that go between individual hospitals that are parts of the network. At the moment, the sort of gold standard for referring patients to other hospitals in our network is really sending an email with patient details to somebody, and who that somebody is depends on you knowing who that person is on the other end who's responsible for receiving those cases, or emailing a colleague at a different hospital. That colleague might be away on vacation or might be overwhelmed and has somebody else who really should be taking the case. And so our hope is to use the same system that we just described for tumor board to also handle these patient referrals and organize all the information centrally. Next slide. And I think this is back over to you, Yuri. Although as a prostate cancer expert, I'm very interested.
Great. Thank you much. Thank you very much, David. And David has been brilliant at working with colleagues to bring this to bear. It requires a lot of communication to roll out these networks, to be able to explain how it could be best, the technology could be best used. But once people sort of understand all the possibilities and configure the workflows the way they want, they have great operational efficiency. And Dr. Einstein's GU oncology group has had hundreds of virtual tumor boards of cases and that they've been able to organize and to be able to do it. So it's a real testament to great collaborative skills from he and his colleagues. And this is sort of part of the knowledge that we'd like to share with everyone on strategies on how to be able to do that. So I'll give you a few more examples of other learning networks. So there is this other network called the Madcap Network, which has existed for over 10 years, led by Dr. Tim Rebeck, who is at both Harvard Medical School, Dana-Farber Cancer Institute, and the Harvard School of Public Health. And so this is work that he and other colleagues across the United States and across Europe have been working together to understand the genetic basis of prostate cancer. And this particular network not only is doing scientific work both here in the United States, but also working with centers in Africa to be able to collect specimens, sequence them in Africa, and then collaboratively work across globally to be able to do analysis of that information to understand how to develop better treatment strategies for prostate cancer. With government grant funding, this was expanded in the last few years, and Alicanto was used as a platform for providing education and collaboration across the center. And at the bottom, you see some educational videos that were developed. And so the groups have been using this type of technology. More recently, we've got a grant to be able to develop a training program for emerging cancer researchers who want to do research in sub-Saharan Africa. And while the focus is cancer researchers in Africa, it will also be open to a few physicians, scientists here in the United States who want to do work in Africa in that area. And so we'll be developing a comprehensive training program for emerging cancer researchers. And the mentoring will be done via the platform through groups that we've developed, both for scientists as well as project managers. So this is sort of a really great opportunity to use a learning network to create capacity and develop the healthcare systems and the research capacity of Africa. So we're both advancing science, but also strengthening the healthcare and research enterprise in Africa. So more to come on this. That program launches this fall, and we're really excited about that initiative. Another group that is using it is MIT. So they've licensed the platform to share best practices in education, and they form 3 super groups. These are large communities. There's about 30,000 plus educators worldwide. And here you see that there's one group focused on education in K to 12, another one that's focused on higher education, and the other one on workplace learning. And then within these communities, they have subgroups focused on specific topics. And so they've used this over the last few years to disseminate the best knowledge on educational strategies and using the collaborative tools to be able to develop implementation strategies worldwide and have those implementers share their lessons learned. And so this continues to grow, and there'll be more of that site available in multiple languages. One of the nice things about our platform is that we can also have different languages and interfaces for that. So there are some other learning healthcare systems as well. Here you see some of the other ones. The RAF network has been in existence for over a decade, and it's from North Africa. It started in North Africa, but focused on francophone speaking oncologists, and working with Dr. Antoine Geisbühler from Switzerland and other colleagues from Europe and across Africa. They develop a network to disseminate education in oncology and other topics throughout Africa in French. You see also the James Anderson Center, which is also another center here in the United States that takes this sort of learning healthcare network concept as an integrated strategy where education, quality improvement, and implementation science are all part of a large community, and all of these groups are working together to have a coordinated strategy for how they do this collaboration across their various hospitals. And you see on the right the World Health Organization developing a community of practice also for health workforce needs. Improved Care Now is another one that focused on pediatrics, that's developing the learning healthcare system within their community. And Hive Networks is a platform that's more based on genomic sciences and developing a community of practice around those scientists. So there are emerging platforms of this, and the idea is to be able to develop tools to allow collaboration, both not only in education, but then moving towards the implementation of those strategies. So what are some of the strategies that you might want to deploy in some of this? And the first part is who should be involved in the planning of creating such a network. And so this is best done when you have a multidisciplinary team of people working together. So it's not only educators and trainers, but people who are researchers in developing the evidence, people from IT staff developing this, need to work with this community to understand what are their needs and develop the collaborative strategies and the integrations that you need for information flow. A lot of this depends on making the system fit to people's needs rather than people trying to adapt to technology. And so I meet on a regular basis every week with Dr. Einstein and other colleagues to understand how the community of users want to best use this and create workflow optimizations, and how do we tailor the ability for notifications and other functionalities to do that. So it has to be an evolving technology and responsive to the growing needs of that community. You also need to work with legal and privacy experts to make sure you've got the security on that. Management teams, I think, are interested in this particularly on the QI perspective, and it gives you a tremendous opportunity to be able to collect data on performance measure across the network. And as you develop this, you might want to have portals for patients to be able to also access that information as you develop protocols that try to provide better patient engagement, better patient education, and adherence to treatment. So the portal can be configured to have patient areas for patient education. Finally, a lot of people who believe in these large-scale networks are sometimes called dreamers or misfits. It's very easy to get siloed and do very well in a silo, but as a healthcare network, we are best when we collaborate across disciplines and across departments and across institutions. And those who have collaborated, in my experience before, are the networks and organizations that have been able to grow and provide better health outcomes and better experience, not only to the patients, but once these platforms are implemented, people feel less frustrated because they have an easier way to connect with those people that they need to connect with. So how did this evolve over time? Initially, it might start with a focus on education and trying to get education on the latest evidence. And as those groups evolve, it evolves to the next stage of developing practice guidelines and care guidelines. And once those are developed, you have the difficult task of disseminating that knowledge and implementing it and operationalize it inside your healthcare system. As you do that, people want to learn from each other, and this is where the community helps each other. And as you develop common protocols and care guidelines and agree on certain outcome metrics, you're able to compare outcomes across different centers. And there, the next level of a maturity of a network is when they're able to compare outcomes and learn from each other at a detailed level and be able to give each other second opinions on difficult cases, as well as be able to compare quality outcomes and be able to learn from each other. And so this is sort of the maturity level of a large network that evolves over time. This takes a couple of years. It doesn't happen instantly. And a lot of this depends on trust and people's willingness to collaborate. And so what are some of those facilitators? I think there has to be a critical mass of people with common needs, a leadership that's transparent about what they're trying to achieve as a collaborative network, and then the community needs to agree on certain kind of common objectives, metrics that they want to collect in terms of data and outcomes. And it has to be a community that's supportive to include others to join the network and be able to to be able to contribute to the network. Those networks that are supportive and inclusive find that there is more energy, and the network continues to grow as people find benefit and a welcoming environment. And those networks that don't do well are the ones that are very narrowly focused with very dominant personalities who don't want to collaborate across their individual silos, or a community that doesn't want to share knowledge. So what's the next phase of these learning healthcare systems? I think we're still in the early stages worldwide to be able to implement them. It's still a very difficult thing to do, not only on a technology level, but in terms of a culture and organizational point of view. But I think these are essential for large networks to be able to implement if they're going to be successful in optimizing their care and to bring the latest evidence faster to the point of care. And to do this, we need a systems-based approach, one that involves key stakeholders working together with patient-centric models and allows collaboration and thinking of how to do this in terms of what's best for patients. So the ability to have virtual tumor boards and patient referral discussions to see where does it make best sense, not only in terms of the healthcare outcomes, but in terms of patient preferences, where they would like to be treated, because transportation in large cities is a big problem as well. Requires thinking this from the patient's point of view. And having these learning networks allows you to sort of strategize of how to give the best care to all patients across a very large network. To do that, we need to build these systems that allow personalization and customization of those interfaces so that the workflows and meet the needs of individual users. We need very good user interfaces, both on the web and mobile apps, so that's available. And we need to be able to integrate these systems with back-end systems for data sharing. Finally, how we evaluate these networks has to be based not only on clinical outcomes, but whether we're providing the right education to the right people at the right time, whether we've improved communication across the network, and whether we have the right QI metrics to be able to collect and there's an agreement. So all of this is doable, but it requires strategic planning and development. And at the center of this is a community of professionals who trust each other and want to work and collaborate to be able to develop all of this. Finally, I want to end with just a comment that if you want to go quickly, go alone. This is an African proverb. But if you want to go far, go together. And in my experience, those healthcare systems where there's a collaborative spirit and willingness to work across disciplines and across centers are the ones that are able to move faster because they go together. There are several publications that will be available online, and they're fairly easily searched on the website. And there's my contact. We're happy to provide answers to anything that we can't get to in the Q&A. And I look forward to connecting with you, learning from your experiences as well, and sharing our knowledge with you. Thank you.